sometimes it's not easy to swallow that answer, but then again, a lot of times I'm able to put light on a subject matter that they are interested in. And so, and I feel that I've established that relationship with clients, and I receive as many birthday cards as I send out to members, and I'm thankful, so that tells me that I have a big family. And
Calling
so,
member services is a nightmare in general. You're going through the
yeah.
loophole. Julie and I
Hmm.
both have tried to help, and it's just they changed the wording almost like it's a car warranty. And I think it's cool that patients
Yeah.
can reach out
Yeah.
to you.
Hmm. Well, the one thing you have to remember is when a member calls into member services, I hope I didn't interrupt you there. When a member calls into member services, everything is in black and white. It's robotic when they're speaking to that representative. It's recorded. It's and we're not, as it's being robotic, it's not always explained in quote unquote English for that member to understand. It's some robotic because it's scripted in front of them. That way, the member services is saying the right thing. They're not putting that company at risk and so on. There's a lot of that stuff. And so I like to think that when my members call me, there are new rules with Medicare. When I speak to a member, I have to record my calls when I'm speaking about Medicare. At the same time, I'm not doing it. I can still speak to them in English. I can still speak to them in a manner where they understand. And so, yeah, it's complicated. And you're not sitting on hold for an hour. Not a lot of times I can get, as a broker, I can come in the back door. I can
Sure.
sit on hold for maybe 5 or 10 minutes compared to somebody waiting an hour. So.
Yeah, and it also seems like these call centers are offshore. Even the Medicare Advantage plans that are local, if you will. I mean, the turnover is huge in these places, and they aren't really educated for complex rheumatology issues. So we've had the experience of literally being on the phone with a patient and their insurance company for more than an hour, and literally they're provided false information. So the service that you're providing to your clients, you are a trusted partner. And I value trusted partners because this office is a trusted partner with our patients. So I love what you're doing.
Well, and I feel like insurance,
Yeah,
whenever we call, their goal is to get us off the phone, whereas you're actually there able to provide the information that's needed, where insurance companies will just hang up on us whenever we can't get to the next level. You're not going to do that because your name's attached.
That, and and as much as my name is attached, I grow attached to my clients. And sometimes it's hard. Sometimes I'm a Jersey boy. Sometimes my emotion shows on my face, but it's not a situation where I'm impacted negatively based on my client. It's just a situation we're in. I want to provide an answer, and I want to be effective with that answer. And to your point of not always having the right answer, you're right. Majority of the time, the last few years has become even more common that it's offshores. You're speaking to someone who has a hard time speaking English, and majority of the companies, however, well, the brokers, the agency managers with the carriers educate us to let our members know that if they do not understand a representative, that they can ask for an English-speaking representative. Well, come on, they're not. And the members aren't going to think of that. They just called a number and expected to provide to get an answer to a question, not to have to jump through hoops or multiple representatives to the point where they can understand them. So yeah, it's hard. And myself, I keep really good notes. A lot of people when they call, a lot of members when they call in member services, I mean, they might grab an envelope or some piece of mail or something, or write down some notes from a conversation, maybe a date, a time, but it's not going to be as specific. I do it every day, so I know what style of notes to reference and to keep a hold of, and I keep those notes for my clients. And so that way, sometimes we have to submit an appeal, or whatever, as we know, the calls are recorded. That's why those notes, one of the reasons why those notes are important. As we submit an appeal, we can say, hey, we called on this day, spoke to this person. I probably had the spelling wrong of their name, but they called this person on this day and this time, and this is a call reference number. When you do that, their backs are against the wall because now you've taken those notes, So, and it's, I treat every client, and I'm not just saying this to say it is true, because again, it took me a while to build my book. I treat every member as if they're a cousin, a brother, a family member, or, if I'm looking at insurance or dealing with it, if my client's dealing with an issue, that's my issue. How have I handled that issue to get an answer based on my knowledge? And so that's how I handle every situation.
Well, it shows, Patrick. It shows in the creativity of your solutions, and it shows in how you navigate a very complex situation. Let me ask you, like in Missouri, from what I can see in our little, not so little Medicare book, it appears that there's about 400 Medicare Advantage plans in Missouri. Why are there so many Medicare Advantage plans?
There's a very large percentage nationwide. When you look at Medicare beneficiaries, what percentage of those have a Medicare Advantage compared to a Medigap plan? I think that's an important point, because as I expand that question, a lot of times there's questions about Medicare Advantage in general. Why not just go straight Medicare, than to deal with the headaches of the Medicare Advantage? And the answer to that question is nearly 70%, I believe, of Medicare beneficiaries are on Medicare Advantage plans. And that's a lot of people. And with that number, every plan is geographic. You have to draw a line in the sand somewhere, these plans based on networks. There's a formula of a plan to determine what the value of a benefits are, whether it be co-pays or medical out-of-pocket limits and that type of thing. And as it's determined geographically, my understanding, you have those in a rural area, it's not so much anymore like it once was, but it would be more recent. But those in the rural areas, their benefits were not nearly as attractive as somebody more in the city or, in the St. Louis area. And it's because comparing population to available doctors and hospitals within that geographic, and again, they have a formula, and it's, I know, and I can explain it in that way. In the Midwest, I'm contracted in multiple states, and actually here in the Midwest, the benefits on Medicare Advantage plans, as far as copays and that type of thing, they're very strong. If you were to compare that to Arizona, or if you compare it to Florida or Alabama, those are common states of retirement states for seniors. My point is, it's heavily populated with Medicare beneficiaries. You would think that those numbers would help in their benefit, right? To reduce those copays and so on. But, you'd be surprised at how much, a specialty copay here, it's not uncommon to have a $25 specialty copay, whereas in Florida, you're looking at $40, or a max out of pocket here in the St. Louis area might be $2,400 on an HMO or $3,800 on a PPO. In Florida, you're looking at $6,700.
Wow.
So it's a broad answer to your question, but it's based on my understanding, and best way to explain it is that it's geographic. And it's based on population and available hospital doctors, that type of thing, which everything has to do with money, right? Everything has to do with availability of funds and so on. And so there's
with the 400 plans, it's not like they have the adequacy. We've learned there's a shortage in most plans.
Right. Yeah. Well, I think that, go ahead, Patrick.
I'm sorry. I felt like a really important part of that, if there was someone listening to this, obviously there will be, as much as there's nearly 400 plans nationwide, our focus is going to be geographic. For example, here in the St. Louis area, there's literally 42 Medicare Advantage plans available to us. So somebody goes on Medicare.gov, they can find, well, it'll show 42. Now, my goodness, hands pulling out the hair, because how do they know what to do? How do they know what plans to choose? They don't know the ins and the outs, what works, what doesn't work. Of course, that's where I step in as a broker representing all these plans. I know plans that work, that are strong, and that are not as strong based on that member's needs, as everyone's needs are different. You take that 42, now you filter it based on HMO or PPO. Now you've cut it in half. And so there's so much language, as you mentioned, there's so much language and understanding to Medicare that we're vulnerable. We're very vulnerable, and without the proper direction, it can really put someone in a bad spot. You'd be surprised at how many members will purchase a plan based on the fluff, based on the extra benefit, being over the counter, that type of stuff. They do not focus on the medical side of a plan. Let's put our feet on the ground. The reality of what we do and why we do it is, I literally could speak to a 100-year-old member, and they say they're healthy as can be, probably gonna live forever. The reality is they're going to use our medical plan. We need to focus on the quality of that medical benefit. What is an HMO? What is a PPO? As I can continue to ramble, there's so much to it, that I'm really passionate with it, and I'm more passionate having the opportunity to explain it to a client, and that way I'm protecting them. So.
Sure. Well, it's a complex issue, but I also feel like this huge influx of choices is all about profit centers. In some ways, we view, as a specialist office, we view Medicare Advantage as a disadvantage unless a chronic patient has their out-of-pocket every January, because if they don't have that, they kind of become the secondary. Now, I understand that for some people, it's probably a good thing. But, and we accept a lot of insurance, but we're also starting to not accept insurances. We've said goodbye to 3 different health plans in less than a year. And 2 of them have been Medicare Advantage plans because of the administrative burdens that are put in front of us. And when we try to work with these plans, they don't value the work we do. That's the bottom line. Either they don't understand rheumatology, or they think they know it better. So it is really a complex issue. And I think that you and I align on, you're looking at an individual situation as we are. It's not one size fits all.
No, it's not. It is. And the most important part, and I have to be careful with the words I choose, but I mean, in blatant terms, we live in a very selfish world. And that selfish world falls subject to the members who really need the benefit. One of the reasons why we run into, in your position, why you run into some of the problems you do, can't speak to them all, but I know as far as Medicare works, there's so many people out there that do not understand how it works. I mean, the insurance company, when somebody has Medicare and then say they go with that company XYZ, well, now that they're contracted with that, and now that they have a plan with that company XYZ, Medicare is not really playing a role. That insurance company now is, they're being compensated by the government to then, and that's how the insurance companies make money. And as much as they're making money, then the government, their ask or requirement is that insurance company follows Medicare standard. Oh, okay, Medicare standard. So in other words, you're saying that the insurance companies are expected to follow what Medicare would approve, what they would not approve. The thing is, it's not something, but they're also given a time frame to do that. And going back to that selfish world, sometimes insurance companies will drag us through the mud, and to a point where we have to submit an appeal or the process. And it could take up to 90 days, as that would be the standard. That's what the standard would be for most situations, not all. But as far as 90 days being specific to when that insurance company is expected to follow that standard, there's 90 days of kicking and screaming.
Patrick, walk me through a situation that, as a broker, an insurance broker, you would submit an appeal to an insurance company. Tell me about that, because I don't understand and I don't have any familiarity with what kind of things you appeal on behalf
so
of
let's
your
say
patients.
let's say that somebody is in a position where they had a stroke or a medical condition, and just we'll say stroke. And now medically, they say that member requires skilled nursing, skilled nursing, and they have to be maintained in that skilled nursing facility. Whereas an insurance company might argue that with that medical professional and say that, well, no, we believe that they obviously, yes, they need the attention, but yet we believe they require home health care. Okay, well, home health care might be a more cost-effective way for the insurance company. Medically, we could argue because we don't know. But you see where I'm going with that? I mean, it's
sure.
I can't really say that the insurance company is just purposely doing it because it's more cost-effective than doing what's right for them. Maybe they have a good reason to suggest that member needs to have home health care instead of being in a skilled nursing facility. We can't speak for that, but as far as the appeal process, that's where you step in with an appeal process. And what you do is you communicate with that member, and you get on the phone with the member services, with the billing department, and then you submit an appeal. And that appeal process, you might be able to discuss with that carrier, what are we missing here? What is this member is entitled to an explanation, not just a number, a number being associated with that claim or whatever purpose. Speak to them in English. Why are we saying that they do not qualify? Is there something that the doctor did not submit properly for them to qualify for this, service? What is it? We speak to us in English. You'll get on the phone. We're not doing anything wrong by doing that, but the process that might be an extreme to your question, but I've taken it to the extreme. And when you do that, you tend to push that envelope. You push the envelope.
Love it.
And doctors, they know, what the expectations are before an insurance. What the process is, the step therapy is before an insurance will cover one thing before the other, right? And that. And so you're going to make sure that your patients follow those steps before you recommend that they process that through the insurance. You may follow those steps medically, but then again, the insurance company may argue and say, well, no, you didn't do it this way. What, really? It's frustrating, but you get on the horn and you fight for the client. And at the same time, it could be something small too. It could be a matter of, a lot of times it's a matter of maybe when the medical facility submitted the claim, they referenced the wrong number, the ID number, or claim number, that is. Or sometimes you need to just ask them to resubmit the claim through the business department. And there's just steps, and a lot of times it's very common to have to call in and ask that a claim be resubmitted a second time. And a lot of times it just gets covered, without a lot of heavy weight behind the phone.
Well, I was even unaware that was even an option, and I love to learn things. So I can tell you from the physician standpoint, the physician appeals and the physician letters of medical necessity often go unanswered because typically insurance companies think of us as unimportant independent contractors. But when the patient does an appeal, the patient files a grievance, now that's a completely different playing field. We learned about this with another group that I actually want to set up a meeting with you and with this team because it's out of the box thinking, what you do, what we do, and now having the patient file the grievance, now all of a sudden that's a game changer. So how does that work in the broker world? If you file or you get on the phone, do you always have to have the patient with you, or how does that work?
Yeah, normally you do, just for HIPAA and so on. You need to make sure for compliance reasons, you need to, that member, before member services will speak to you about the specifics of a claim, that member would have to be on the phone and have to provide permission before they would speak. And but then again, and that's okay, I'd rather the member be on the phone with me when we're
Sure.
talking. That way, if there is a question, I'm referencing it in the right way, not putting myself at risk. But typically it is a matter of calling into member services. I'm going to be a broker. When I call in member services with a member, they know that I'm their broker, as my information would show up on their screen. But even with that, they're not just going to talk to me about anything. We'll get the member on the phone. Compliance purposes, we'll ask them again, does Mr. Randolph have permission to speak about, do we have permission to speak to Mr. Randolph about this particular situation? Yes or no? That's a yes. And then we ask questions, we have a conversation, and I normally am guiding the conversation because the member, it's okay. It's some do, but a lot of them don't know the language. They don't know how to get to the point,
Sure.
And they may feel overspoken to, maybe, or just intimidated by a conversation, because again, as you mentioned earlier, it's not always, it's scripted in many ways, because
Sure.
that member service has to protect themselves as much as, we have to protect ourselves. So, but yeah, so that's what you do. And then you help walk them through that stuff with that member, and you ask member services to, yes, we would like to file an appeal, or maybe we need to resubmit the claim in the right way, or tell us what they're missing. If I'm asking the member services, what are we missing here? Let's get it done. I'm willing to help this member if it's a matter of contacting the doctor's office, which I've had to do before. Contact the doctor's office as far as the signature, this one member is one of many members that
Sure.
a doctor is receiving information on. And as much as we're not saying that member's not a priority, but that large number of members that a doctor has a responsibility for, they're all a priority, but there's only so many hours in a day that we can accomplish to, master that. So you can go on and on and on about it. It's a matter of getting on the phone with the representative and member services and actively together through a call, discuss it, process it, do what you need to do. And then we follow up on it.
Your clients must feel very well served, because one of the first things we do before we'll advocate for a patient is we get them on the phone and say, do you want to do what your insurance company wants you to do, or do you want us to advocate for you and with you? And if they say they will just do what their insurance company wants, we have no problem with that. Go ahead. Dr. Bach will write the prescription for whatever it is that your insurance company wants. If they want us to advocate, it's really important that they stand shoulder to shoulder with us, because we can't do this without them. And I feel like you have a similar philosophy too. Tell me, what is the future? What is the future, Patrick, in your world, of what's going to be happening with insurance?
Well, it's hard to say. There's a lot of things you can say, you can't say. Of course, there's always compliance, reason for compliance reasons. We all have an opinion. I see that the energy that I see, I focus when I meet a member, I turn over every stone, make sure that they know every single available option to them. And whether it be a Medicare Advantage or Medicare by itself, Medicare Advantage or Medigap supplement plan. Turn over every stone. If I was to do that, I'm actually, and others might have a different opinion, but I can see that I feel that more are leaning towards the Advantage side of things. They get with their group of friends at their little Medicare troop fire, and they talk about their plans and the benefits and so on. And there's no cost to have the plan. You pay to use it. A lot of people, and especially in today's world of the economy, they cannot afford these Medigap premiums. You're looking at premiums. You're starting out with a Medigap plan. Somebody new to Medicare, about $150 to $170 a month. For a Medigap plan on top of their Medicare Part B of $174.70 for most. It could be higher for them, but yet a lot of times they just can't afford it. They're not able to afford that. And so there's a lot of reasons to your question why someone might choose an Advantage plan over a Medigap. where do I see ourselves heading? I see the premiums of Medigap plans increasing, as everything has and will. I don't see it going down. I have seen premiums go down with one company once in my 13 years of servicing members, but they normally go up. So medical costs continue to go up. A lot of people don't realize that, there's so many situations that, there's a medical bill. If I have a procedure done and let's say I'm not able to pay the bill, I always tell members, a lot of times things go on behind closed doors that we don't know about. It being from the billing department, for example.
Sure.
I have a member who they had a replaced knee one year and she didn't receive a bill. I said, don't worry, let's say her name's Lisa. Lisa, don't worry, don't worry. They know you were there. Then the next year she calls me, can you believe they charged me for my other knee? Well, you got two for the price of one. But the point is, you sometimes think something's covered, sometimes it's not. It's affecting all of that. There is stuff that's going on behind closed doors that we don't know about. And a lot of times, let's say somebody can't pay a bill or don't pay a bill, don't just write it off. We don't. If medical doctors and hospitals or whatever, if we wrote those expenses off, well, then we're potentially taking a loss, right? I mean, they're going to protect themselves financially. We're just going to move that. We're going to take that loss, and then that's going to help increase the costs of other services, across the board for everybody who's paying. I mean,
Sure.
Medical costs continue to go up for so many reasons, but that's one. So where are we headed? I think that's the American way. I feel like that's a common theme. I do see more people going on Medicare Advantage plans. At the same time, you read a lot of articles, as I read recent, that a lot of medical facilities, doctors are opting out of Medicare Advantage plans.
Yes.
I mean, I get it, but then again, where does that? So when I do that, I understand the medical side, the doctors and so on. I understand their opinion, their purpose, their why. And then, but also too, I understand the members' side. I mean, if we take that away, if let's say 50% of Medicare beneficiaries on an Advantage plan, and then we take this away, where are they going to go? There's so many seniors out there that they're on Social Security. That's their retirement. They can't have a Medigap plan. And so there has to, unless there's another service, they're on straight Medicare. Okay, now you're on 20%. You're responsible for 20% of expenses. We're setting that member up for failure or medical bankruptcy, unless they're knocking on the door of Medicaid. So it's a vicious cycle. That's not me speaking as a broker. That's me speaking as an individual outside the bubble looking in. I see and maybe there's some things I'm not familiar with. Maybe there's some, and if that's the case, well, then I need to do the research to understand it more. But it's one or the other, right? I mean,
we're working with a couple groups that are actually working towards a Medicare for all, to where hopefully we would put the money that goes towards the Medicare Advantage plans and make Medicare better. Because if everyone just has the straight Medicare without having to pay for the Medigap and there's dental coverage and all these other coverages, we wouldn't need to go shopping for all these different ones and be covered.
I think that there's way too many people that are making way too much money, that Medicare for all will not happen in my lifetime. But if for some reason it happened in my children's lifetime, I think it would be like a specific company that I do not want to do business with. And so I don't know what the crystal ball holds either. But what I know for sure is that the doctor's offices are buried in Medicare Advantage administrative burdens, prior authorizing inexpensive medicines. Like, it's so not right. It would be, if we could just have our patients cash pay methotrexate for $11, that would be our preference. But the Medicare Advantage members, they are like, no, this medicine should be free. And I get that. I serve underserved people. So we fill out the prior authorizations, but the insurance companies answer to shareholders. You and I, Patrick, we answer to patients. That's our difference. Okay. We are, we get the phone calls. We're the boots on the ground. These insurance companies are literally for-profit centers that their job is to make more money. So it really is an interesting position that everyone's doing what they're paid to do, right? So I don't know what the future holds. Any parting thoughts for us today, Patrick?
I'm curious. I have one question to that point when it comes to insurance, because again, when I think about this stuff, I try to have an open concept across the board, because I don't think it's just the insurance companies or just the doctors, so on. You know, in the pharmaceutical side too. You know, I mean, because my understanding is the insurance companies, they're going to contract with the pharmaceutical company. So, you know, so that pharmaceutical company, for example, they all have an active role place that helps dictate or determine what the value of a plan might or may not be, you know. And so we live in a selfish world. We just do. And there